Okay, we are back to do the last two cases. We're going to start with Brianna. Brianna is a 37-year-old woman who just gave birth to her first child, a male with features characteristic of Down syndrome or trisomy 21. You are the postpartum nurse. She opted not to have prenatal genetic testing, although a routine ultrasound at 12 weeks did show a thickened nuchal fold. The infant had decreased muscle tone at birth and cyanosis that did not respond to normal resuscitative efforts. Further testing revealed that the infant had tetralogy of Fallot. Heart defects are more commonly associated with Down syndrome babies, so the pediatric cardiologist is recommending surgery. Whoops, let me go back. Sorry. You've been caring for Brianna since her cesarean section yesterday. She has not visited her baby in NICU. She has a flat affect. She originally indicated that she wanted to breastfeed the baby, but she's declined to pump or hand express to initiate lactation. She tells you that her conversations with the neonatologist and pediatric cardiologist and states that she's overwhelmed by all the information. She claims that she never saw this coming. During your assessment, she states, I was 36 when I got pregnant. That's not that old. I took my vitamins, I exercised, I didn't have a single glass of wine. I swore off sushi the entire 9 months. How did this happen? As a nurse, you need to have accurate information and also sensitivity to Brianna's feelings. So what is your understanding of how the infant came to be affected with trisomy 21? And if you look at the choices below, was it caused by an environmental exposure to teratogens? Was there a family history of the condition? Was it inherited from the paternal Y chromosome? Or is it caused by a mistake in duplication of chromosome 21 and more common in older mothers as their eggs age? Correct option is number 4. Trisomies are usually caused by an error in duplication and division of genetic material during meiosis. The only exception to that is when a parent has, either parent, could be the mom or the dad, has a translocation that involves chromosome 21. So it could happen in a sperm cell, but it's more likely to happen to moms because as they age, their eggs get older. We're born with all the oocytes that we'll ever have. There's usually about 1 or 2 million of them. But then the development is paused in prophase of meiosis 1. They don't mature into functional gametes, and that's where that division of the chromosomal material happens until a woman ovulates. In older women, and 37 is not terribly old, but remember her eggs are now 38 years old, the cells might be of lower quality, and they tend to make mistakes in duplication and division of chromosomes. That explains the risk for miscarriage as women get older because most trisomies, the vast majority of them, are incompatible with life. Interestingly, the majority of children with trisomy 21 are born to women under the age of 35 just because that age group has many, many more children, so it just the percentage is lower, but the overall number is higher. There's really nothing Brianna could have done to avoid conceiving a child with a trisomy. She could have had prenatal testing and chosen to terminate. She did not do that, and many women would not. It's a very personal thing. So later that day, lactation consultant visits patient. You come into the room. She's crying. She's hooked up to the pump. She states, "Can I tell you something? I can't stand the idea of having a kid with a serious disability. I can't even look at kids in wheelchairs. I always look away. And I wanted to have at least 2 kids, but now I'm afraid that if I get pregnant again, the same thing will happen. What are the odds of this happening again?" So you give Brianna a box of tissues, sit down, and prepare to answer her question. What are the odds of recurrence in a subsequent pregnancy? 50% if the father carries a recessive gene. No higher than for any woman at the same age at the time of conception unless she or her partner is a translocation carrier. Lower than a woman who's never had a pregnancy affected by trisomy 21, or the only way to predict the odds is to test the maternal karyotype. Correct options number 2. Brianna's odds will be the same for any woman her age at the time of conception, unless she or her partner is a translocation carrier. They are not affected by paternal carrier status, and the maternal and paternal karyotypes don't usually predict the disorder because translocation carriers are rare. If you remember our content from last week, I did a little piece on Robertsonian translocations, and 14 and 21 do tend to stick together. So families that have a lot of kids or more than what you would expect affected by trisomy 21, or families with a high rate of miscarriage, that's usually like a red flag for translocation carriers. The odds aren't different because she had a baby with trisomy 21. Every new conception is a brand new toss of the coin, roll of dice, whatever you want to call it. Anyway, okay, so let's move on. We're going to talk about Maud. Maud is an actual patient that I actually took care of, and it didn't happen that long ago. I want to say it was maybe 2 years ago. She came here from Haiti. She was 39 years old. She was in labor. It was her second baby. We were starting Pitocin on her, had her hooked up to the monitor. I had 2 patients at the time, and I was in a different room. I had just done an epidural with the other patient, but I was watching both screens. And I saw some things I didn't like. She had limited English proficiency. She requires an interpretation for Haitian Creole. During her prenatal care, she had NIP testing. NIP testing is non-invasive testing. It requires maternal serum sampling, and it looks for fragments of fetal DNA when cells are discarded. The testing revealed that some fetal cells had trisomy 16. So she was referred for amniocentesis, which is more diagnostic, and that revealed mosaicism. Some fetal cells had 46XY, some had 47XY, and that extra copy of chromosome 16. Ultrasound findings didn't find anything really terribly unusual, except that the baby was very small in the 3rd percentile. It was a boy. Maud also had gestational diabetes. That is not her real name, by the way. I just used the name Maud. I'm trying to be HIPAA compliant, but she had insulin-dependent gestational diabetes and chronic hypertension. Okay, so imagine you're the nurse in labor and delivery and you've been assigned to this person. There's a note in the chart by the perinatologist, and it says that the significance of the finding was explained to the patient using certified Haitian Creole interpreter, and that she verbalized understanding. The note documents that she declined termination of pregnancy and stated it is in God's hands. There is documentation that 2nd and 3rd trimester ultrasounds were done, but no reports in the patient's chart. So you don't really see what they say. You're just told that there were no fetal anomalies that were seen on gross anatomy scans. While you're caring for Maud, external fetal monitoring reveals a prolonged deceleration of the fetal heart rate with a nadir, which is the lowest point, of 50 beats per minute. And we know that normal is 110 to 160. So you run in there, do intrauterine resuscitation, flip her to the left side, run your fluids, turn off your PET, and the baseline recovers to 100 beats a minute, which is an improvement, but not back to baseline, still reflects bradycardia. An arrhythmia is audible, so we inserted an internal fetal monitor. The OB provider is called to the room. She was a midwifery patient, but the OB provider came in and starts to explain options for cesarean versus vaginal delivery using the Sericom interpreter line. Now here's the problem. The OB provider had limited understanding of the clinical significance of mosaic trisomy 16. She tells the patient that the safer thing for the baby is the C-section because the baby's having some changes on the fetal heart monitor that tell us he's not tolerating labor. But the trisomy might mean that even if we do the C-section, the baby dies anyway. She explains that there are risks to Maud for the surgery and asks the mother what she wants to do. She's got a lot of risk factors. She's a little older. She's got hypertension. Her sugars are high. She's at risk for bleeding. She's at risk for infection. She's at risk for all the, surgical complications like DVT. And she goes through the whole laundry list of this could happen, this could happen, this could happen. She asks the mother, so what would you like to do? And the Haitian Creole operator was so confused. I'm not even sure that some of these words had direct translation into Haitian Creole. I don't believe genomics is a big part of Haitian medicine. There's only one neurologist in the whole country, so I kind of doubt it. Patient does not appear to understand what the provider wants her to do. And she kept saying, this was like a repeated thing, it is in God's hands. It is in God's hands. Whatever happens, it's in God's hands. And the provider said, yeah, you're saying it's in God's hands, but we really need to know, what do you want to do? So the patient says, whatever you think is best. And you could see she was utterly confused and frustrated. So let's go back to a little bit of knowledge can go a long way. What's the simplest explanation of mosaicism? Number one, some cells in the body have the genotype for the genetic disorder. Other cells have the normal genotype. Or number 2, all individuals with mosaicism will show a similar pattern of disease. Number 3, the phenotype of the individual will appear normal, although the affected gene is silenced in all cells. Or number 4, mosaicism is a pattern of incomplete dominance where the normal chromosome and the abnormal chromosome cause a milder form of the disorder. Let's go back. Skip right over it. Correct option is number 1. Mosaicism is an anomaly in some cells of the body. Mosaic trisomy 16 happens in early embryonic development. You have a euploid zygote. So the egg was normal, the sperm was normal, they combined, had a euploid zygote. And then somewhere in that rapid cell division and differentiation phase, one cell made a mistake, went a little bit rogue, and had an extra copy of chromosome 16. Every cell descended from that cell will have the extra chromosome. It doesn't look the same for everybody. It depends on when it happens and which cells are affected, which cell line we're looking at. Sometimes the deviant cells are confined to the placenta. It happens like almost at the end of embryonic development, and the baby's body has no actual cells. Sometimes a lot of cells are affected. It happens earlier in embryonic development. And sometimes it depends on which cell it is, because if it's a cell that doesn't require a lot of expression of genes on chromosome 16 for its normal characteristics, you might not see as severe a disease. But there's not one genotype that's silenced. There's no, it's not like X inactivation, you have an extra chromosome and you shut it down. The number and type of cells that are affected will determine the phenotypic expression. It's not related to incomplete dominance, which is an interaction between two dominant alleles that are in every cell of the body. So think of your example where we have, height could be one, where you have a tall parent and a short parent and the offspring is sort of medium height. Or curly hair, straight hair combine and the offspring has wavy hair instead. So that's what mosaicism is. During this conversation, the fetal monitor continued to reveal fetal bradycardia and anorrhythmia, and it was a long conversation. The OB provider would not allow the patient to sign consent for the procedure until she definitively indicated that she understood everything she was being told and agreed to do it. The maternal fetal provider who counseled the patient, outpatient, is unavailable by telephone, which he could have at least shed some light on what that genetic disorder meant. 45 minutes of discussion ensued, and the interpreter kept asking, interpreter number what, asking for clarification. What does that term mean? So she didn't understand what the term meant, and she didn't know how to translate it. So we're not really even clear how much information Maud got at this point. It was not a teachable moment. So I know you're all in suspense. What happened? What happened to the baby? Did she have the C-section? Did the baby die? Was the baby really deformed? Or, what happened? Patient indicated she wanted a cesarean. She signed the consent. Baby was born with APGARs of 8 and 9. Perfect. No clinical signs of the disorder whatsoever. Had a perfectly normal head-to-toe exam. And he breastfed like a champ, better than most babies. And he stayed in Maud's room under the well baby census, requiring only routine care. They did do genetic studies, including an SNP microarray. We'll talk about that later when we get to genetic testing. But no further information. I never heard back. And I did ask, does anyone know what ever happened? And my guess is, if no news is good news, if I hadn't heard about it, it was probably not as severe as everyone thought it might be. Okay, and so we're going to stop here, and I'll come back for forensic nursing and eye song.